So welcome back, ladies and gentlemen. We start live sessions, and we start from Homolka. And the first case should be PV isolation using single-shot device with PFA.
So today's case, the first live case, is a AFib ablation using a single-shot pulse field ablation. Here we have a 63-year-old male with CHA2DS2-1, low BMI, but diabetes mellitus. He has borderline ejection fraction, mild mitral regurgitation, and enlarged left atrium. He has a history of persistent atrial fibrillation. He underwent one electrical cardioversion in February, but he presented yesterday at admission again with the arrhythmia. The patient suffers of palpitations, and he is anticoagulated with rivaroxaban. Here you can enjoy the 12-lead EKG from yesterday, where we see atrial fibrillation, and the 3D model of left atrium here, showing the left common.
Okay, Pavel, thank you for introduction. So can you switch, okay, fine, we are here. So can you give us the main screen, the template screen, okay, guys? And we will show you the technology, okay? So as we are speaking about this single-shoot catheter, so this catheter is named Farawave catheter, which is based on over-the-wire system. So inside, in the central lumen, is the CD5 wire, and actually I will show you the two poses. So the catheter is designed to get PV isolation first, okay? So for PV isolation, the first shape is using basket, labeled basket, and we use we have some information from our first studies. So the standard application is like 4 applications with a basket, actually 2 applications and then turned by 1 quadrant. And from this shape, it's going to the flower position, the flower form. Actually, it's very good to adapt the splines, but there are 5 splines with 4 electrodes, so 5 splines. Actually, it's good to shape the catheter to fit the PV ostia. So this is about the catheter itself. You can show also as well the console. We are able to use 1.8, 1.9, and 2,000 volts. So actually, we are, for all our procedures, we are using 2,000 volts because we have no reason to make a lesson, because it's not about irreversible or reversible. So the console is very easy to use. So actually, when we are in the position, we confirm the position and charge the catheter or charge the energy, charge the generator, and then deliver. So actually, where we are. So we are now inside the left atrium with the catheter. You can see eyes, you can see fluoro, and you can see fluoro image integrated with CT. So on CT, you will see actually the catheter positioning and catheter shape, and eyes, you can confirm the contact or just maneuvers with the catheter. So now I will go to the left common position with a basket form. So I will put a little bit fluoro on active screen. So actually, you on the eyes, you see pushing the basket towards the PV ostia. So actually, I'm clearly in the contact while we have atrial fibrillation, which is a little bit like nonsense because we really want to get atrial fibrillation, like proximal atrial fibrillation patient, but what we can do. So actually, you can see on the Pruka screen live, very nicely, on the screen, this 5 from the 5 spines of 5 electrodes recordings. So we are ready to apply, and actually, as we discussed, we are performing the case in deep sedation. Okay?
So we have to stop a little bit because they don't see anything.
Okay, so guys, can you get the template on all the screens? on the main screen, I don't want to see us in the two screens. Okay? Can you give a bigger the template screen, guys? What we are doing there, okay? I don't want to see us twice. Okay, it doesn't matter. So we need to save the time. So actually we are ready for application, right?
Okay.
So go there. So now we are going for first application. So be focused on eyes, be focused on the live Pruka, okay? So guys, let's go. And I will shoot a little bit the fluoro to just visualize the movement on the screen, okay? So the really first application, let's go. Okay, so there are all the pulses in this position. The patient didn't move too much, and it is a very nice in a quiet position. So let's go, let's go, let's go. So charge, please, to make it faster. So after the second application with the basket position, I need to rotate. I don't want to get fluoro. So on eyes, I can see rotation, and on the live Pruka, you can easily see the only far field. But actually, we are not able to just recording the deeper. So let's go, let's charge. And we need to go faster to fit all these veins. Okay, go. Charging, just charge. Okay? Okay, so we are ready with the 4 basket applications. I'm going to flower position on eyes. You can see very nicely the flower position, and I will show you. So when I have a flower position, then I love to go with the sheet really behind the catheter itself, and it's not prolapsing. You need to be careful when the spines aren't going inside the vein, so which is not the case. So we are ready to apply. Actually, on the live Pruka, you can see the changing the potential. So still we are really affecting the broader area. Let's go. First flower application, second flower application, please. So we are wasting time by charging, okay? So if we can increase the speed of the procedure by charging, shoulder charging, it would be nice. Okay, let's rotate. I will rotate under floor. I really want to see the floor. Okay, now I rotate, and actually I'm not prolapsing, okay? I'm a little bit careful because it's a 35 millimeter catheter. Actually, we have 2 sizes, 31 and 35. So we are using 35 because of left common. Okay, let's go. And left common was calculated for like 28, 29 millimeters, so it should be okay.
Last one.
Okay. Okay, perfect. So while we have a left common, so actually I am really ambitious to try the different cannulations. So actually I really want to try. Honzo, can you make the virus shorter? Let's like go into the inferior part. So we are in the inferior part, right? Oh, now it's perfect. It's a different branch. Perfect. So let's go with basket. And there are only far fields. So actually, we have we probably can say that even with left common, we don't need to apply any other energy. With the flower, it's changing. Not really. Okay, so I think if you agree, I will stop here for the left, and we will move to right. Okay, go. Okay, perfect. Okay.
Okay.
So we have on the eyes, we have right superior. It's very nice vision. It's perfect. So now I'm going to get again the basket one, and actually on the fluoro, look at the fluoro. We have very nice, fitting even on the CT, a little bit like off label, but it's a really good even CT integration. Let's go. So we are ready for another applications on the right upper. Go, go, go. Okay, perfect. One more. if somebody has a question, people, well, you're welcome to.
I don't have a
get
question
asked.
here, but maybe a recommendation. Next time when you do the case, please change the color of the recordings, intracardiac recordings to yellow or something which is visible, because this green
Yes,
is
actually,
almost invisible.
Can you make it like bright?
Light color on Pruka.
Because
Nice
people
colors on Pruka.
cannot see
Peppa is
the
right.
disappearance of the signals.
No, I hate this green. Okay,
Yeah,
fine, you are right. Okay. Okay, oh, look, what's happened? The spines are too close. It's perfect because it's a limitation of what we did. So actually, we interrupt the application while we are speaking, okay, too much. Okay, so now we are going for another basket. So how much basket we have? 4?
3.
Okay, let's go. Jacques, you should be a little bit faster, okay? Now it's perfect. Thank you for changing.
Last one.
Okay, last one, okay. Perfect. Go, 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 Peichl. Okay, now we will change for flower. I will check on, oh, perfect. Okay, look, they're really not prolapsing. It's perfect position, fitting the ostial. Let's go. Please add some anesthesia or some sedation, please. So he's a little bit like, I don't know what he's doing, but he's not happy. But, okay, so listen, we have a patient really sedated, so no any relaxation, no any other drugs. And actually, I forgot to say that we are overshooting by atropine in the beginning. Like, go, go, go. Jsem to chill. So we are a little bit using like atropine 1 mics before the applications to avoid the temporary pacing. And actually, with this strategy, we really don't need to use any temporary pacemaker.
Let's go
Okay.
for inferior vein.
So now we are ready to go to the right inferior. Okay, okay, ready to go. Okay, we are there. Perfect. I'll pause again the basket. So the last vein is going. A little bit deflect more. Okay, perfect.
Nice signals.
Nice signals on the Pruka. Okay, nice, very sharp signals. It's very important. And look at the after, look, disappeared. So it's really, Hiroshi, it's really acute effect, as you were speaking about. And because of, we really want to be sure that it's lesion are durable. So we really create this 2 or 2 + 2 or 4 applications for basket and 4 applications for flower. Okay, let's go. So this, now last basket application for the right inferior. How much time we have, Pepper? Left.
3-4 minutes.
Okay. No, 3-4 minutes. Perfect. So we can show you the integration, how we use the integration. Okay, perfect. So let's go, flower. So we need to have like just like 4 applications, and we will show you, the principle of the posterior wall a little bit starting, and we will interrupt. And please, if you can, come back in the end. So we will show you maybe more the results or whatever, okay? Okay, I will rotate, perfect, and I will make a little bit more. Okay, now I'm covering better the inferior. It's inferior. I was worried about the inferior part. Okay, so in 3 minutes it's perfect, Pepo. It's perfect, it's perfect. No, bezvadný, protože while we are going to the posterior wall, okay? So, hotovo? Mm-hmm. Okay, so we are live? Okay, okay. I really want to get, okay, let's go here. Okay, and now I will stay in the flower position, go far out, and now we will be using the, posterior wall integration. So please get active. And so the guys can see in the auditorium. Okay. Okay. So I'll start from right side. Okay. And you can see on the integrated, okay, I will make live. So we can use the posterior wall, I mean the CT for posterior wall ablation. So let's go for flower on the posterior wall. So actually we have 2 applications for flower on the posterior wall each. Okay, let's go. And actually guys are marking the position. Okay, perfect.
Wipe out all signals on posterior wall, you know, based on this
No,
integration. of
well,
images.
just, okay, let's go. Okay.
It's like box lesion, more or less.
Okay, let's go now. I hate box lesions with RF, but I love this posterior wall application of PFA. I must say, let's go, application. Let's
See
mark the
again, the
position,
signals-
and we need to overlap, okay?
Signals are disappearing.
Look
from
at the signals.
lines.
Fantastic.
You see
Let's
it's,
go one more.
completely
See, it's
empty now.
empty now.
So actually, if you wait 2 minutes or 1 minute, it doesn't matter because we can just finish the posterior wall
Okay, we give you 2
application.
minutes more.
Okay, we give you 2 minutes more.
Perfect. Let's go one more here. So
questions?
the first
Anybody has
line is
questions?
yes. Let's go questions.
No
I
questions.
love questions.
No questions.
No, let's use this because there are left one more. I need to connect this left common. So I'm finished with the upper line, so-called like upper line of the posterior. Now I'm going to the inferior line. Starting maybe on the right side. Right inferior, okay. So very close, so perfect, okay. So let's try to go here. So it's inferior part of the posterior wall. Mark it. Perfect. One more. Shaku, one more. Fast, fast, fast. We have only 1 minute. Okay. Let's go more. Okay. Now, happy here? Okay, let's go. So we are overlapping.
Guidance of fluoro, or
Go,
you
go,
can
go.
do it with intracardiac echo guidance to cover.
Why you are
all
marking this
posterior
inner spot? Guys, I don't like this marking. It's not proper. Who is doing that? Who is doing that? Go, go, go. It's bad. Pepe, I will show you live. No, they are marking. Who is there? Who is there?
Michal, it's okay. It's nice.
No, it's Philip's guy. It's a Philip's guy. I don't know why he was doing this. This is fucking bad. Okay, let's go one more.
Things done.
Actually, Pepo, so let's you explain. We are finished, or we nearly finished. But you know, actually, what he marked, it's not proper. Okay, he marked because it's outside guy. He's very nice, but he did very bad way. So actually, we usually mark the splines, the outer splines, because it's active splines. Okay,
Yes,
so we need to really mark differently. So I don't know why decided to do that. Okay, so our guys doing better. So actually, let's finish here because we are, as you agree probably. So we finish with PV isolation for all the veins, and we will show you in the end the proof of that by electroanalytical mapping, and then we really covered the posterior wall. Maybe I will add one more lesion, okay?
Okay,
So,
thank you.
so
Thank you for
that's
demonstration.
the
We come
final.
back later on, okay?
Okay, hello, this is IKEM EP Lab number 3, and we are about to present you an ablation of persistent atrial fibrillation. A little bit something maybe different from yesterday using the Afera system. Can we switch to that for me to introduce the patient? Can we switch on the screens, the review screen? So we have a 56-year-old male with a history of arterial hypertension. He has a history of atrial fibrillation since about 6 years. He had one cardioversion about 5 years ago. And during the COVID, he had a recurrence of AFib. We don't know really when it happened because there was the time that the people were not that willing to come to a hospital. But he had a cardioversion and he had an early recurrence of after 10 days. He felt much better during the sinus rhythm of these 10 days. He has an enlarged left atrium with lavi of nearly 60 centimeters cubic, and ejection fraction is normal. He's on propafenone, and he came in the hospital. Can be next slide with the atrial fibrillation. And so we're using general anesthesia. We have a left groin echo and ICE and CS, and on the right groin we're using a Gillis M sheet to do. And I will give my word to Elad.
Okay, so can you hear us? Great, so thank you. Thank you for inviting me to work with you, with Peter and with Joseph. Thank you very much. So you got an introduction on the system yesterday with a very nice case in another patient with persistent atrial fibrillation. And you have seen a couple of demonstrations in lectures about the Affera system and the sphere catheter that is designed for focal ablation using either RFA or PFA. I'm not sure if you can see the fluoro image.
Can we switch to
Can
fluoro?
you see the fluoro image, please?
Just let it takes about 5 seconds to do it.
Here we,
No, fluoro.
fluoro, please. So we can tell you what we did so far. So so far we went transeptal. We created a quick map of the left atrium, and we'll show you the voltage in a minute. But I want to start by showing you the catheter, how it looks on the fluoroscopy. You can see that you can recognize the struts very clearly, and you can see that they are, let me just stop on fluoro more. You can see where the sheet is, and you can see where the catheter is, and it's now at the os of the right superior pulmonary vein, so it's very easily seen on fluoroscopy, but it also very nicely seen on ICE. It has very nice echogenicity. Maybe you can see the ICE, I think, in the conference. Maybe like we can at least show you the
Can you go a little bit slow it out?
Here you go. I'll take it out a little bit, and you can see the catheter, how nice it look and it recognize, and you can see the venous, the right superior vein os. So we can correlate what we do in the electroanatomical map with ICE, and the correlation has been excellent, which suggests that the mapping is very, very accurate. Now, before you joined us, we mapped the left atrium and we did a voltage map during
Můžeme ukázat Affera map?
During atrial fibrillation, and we're going to show you the voltage map. Wojtek, can you take us through the voltage map, please? Thank you. Okay,
Rotate.
so maybe you can zoom in a little bit, because I want also to emphasize the high density and high resolution of this map. Now ignore the patches in the voltage, because this is again mapped during AFib, so the voltage is not very accurate. We'll do a voltage map after we ablate, but you can see the number of points, and you can see the size of those points. And obviously with 9 very tiny electrodes on the catheter, we can record very small signals, and we can do it very quickly, as you saw yesterday. We started by isolating the left veins. Wojtek, can you show a little bit the left veins? The green tags are tags for pulse field energy, pulse field ablation, and we did the left side completely with pulse field. The left-sided veins, the isolation took 7.5 minutes, and we had an entrance block. We obviously have not checked for exit block because the patient is still in AF. And our plan for this, for Peter patient, is to isolate the right veins, and then we'll do a posterior wall isolation. We'll do a roof line and another line at the lower level of the veins, which will be a box posterior wall isolation. If the patient transitions into, or either terminate his AFib, that will be great. If he transitions to an atrial tachycardia, we'll show you the utility of this high-resolution mapping system to map atrial tachycardias. But if he remains in atrial fibrillation, we'll cardio over the patient and stimulate to see if we have an organized reentrant tachycardia that we can map. But regardless of this, we are going to do a mitral line and a CTI. So for the sake of time, maybe we can start with.
And we can show the electrograms prior.
We can start with ablation. Now, let me see. You see on the left side the real-time. So you see the two views from the map, and you see the electrograms in live view. Now, I want to make sure that you see what happened to the electrograms immediately
Maybe
after ablation.
Maybe we can
So-
put a Pruka screen on.
I think they see. Yeah, they recognize this. You recognize the signals over there, Joseph?
Can we just
You can see a recording.
Pruka
parallel
screen
to the
online
map.
on the?
They can see. They can see. Okay, so look at the electrograms. I'm going to apply the first.
So hold on, just can we switch to Pruka online? Real time. Okay, can we change? Okay.
But I think they can see this also. Okay, so we're going to apply the first lesion now. So remember those electrograms before ablation. And let's look on the electrograms after ablation. And they are gone. You see, even when I move like 5-6 millimeter, this is 6 millimeter away from the first lesion, there's still no electrograms. Now, when I move like 8-10 millimeter, you start to see electrograms. Just to
go
give you
the
the
map?
idea.
You see signals here as well, so it's you see small movement, and
You
there are
prefer to
still
see
no
the
signals.
electroanatomical map?
Yes, they have now.
Yeah,
Okay.
We
it's
want to
okay.
give atropine
It's very
as we have
instructive
pauses.
now.
Can we give atropine?
We have a little bit of pauses. I don't know. Let's see. Can you do view 1, please? Voida, can you show us a little bit lower? Yeah.
So you will do now a circle on the right side, and then
So we'll
what-
isolate the right veins, and then we do the posterior wall box.
Now electronic capture.
I do.
Can we see the map maybe? Because there is not much to be seen on this screen anymore.
Maybe you can also appreciate the ice, the contact on ice.
Yeah, that's what we were discussing, that this catheter very nicely sits on the tissue because it's a little bit rough, so
show us a
it
little
does
bit
not
lower.
slide like a conventional tip, and it is still flexible, so you can really adjust the contact with the tissue. So it is very nice to manipulate the catheter. You see
Let's
that
do.
it's,
You know what,
it's
guys?
very-
I'm going to show you just an RF lesion. Joseph, can you hear us?
Yes.
So I switch now to an RF lesion, and the RF lesion is going to be 5 seconds, and you can see the heating on the center of this catheter, the bullseye around D3. So we
So-
applied one RF lesion
So
there.
these
We're
lesions
going
will
now
be
back
marked
to
by red.
PF as we
red
go a little
lentils.
bit closer to the posterior wall.
Since they are thermal,
And we're going to go a little
we
more
don't want to
posterior.
ablate on
Perfect.
posterior wall, but anteriorly you can use RF.
But the,
Posterior
as I
will
show
use
the,
only PF.
my lecture, first pulse, eliminate potential. If you go next spot, no potential, right? So therefore, we're not doing the electron-guided ablation, just connecting. Okay.
That's only for communication.
Okay.
But you
Okay.
don't have, you can speak.
So you see what's going on? Ablate, eliminate potential very nicely. If you go next spot, we never ablated, already potentials disappeared. But still, we need to connect the region. It's different from RF.
You see very nice contact of the catheter with the tissue here, see? On ice. It's sitting where you
Can
put
we
it.
hear Joseph more? Joseph, we don't hear you so well. Can we
You
raise
don't
the
hear me
volume here so
well?
we can hear the conference?
Well,
Yeah.
I'm just saying that the catheter contact is very good on the tissue when you look at intracardiac echo.
But there is good heating there. Okay,
This
is
so
perfect.
if you remember from yesterday, I'm going to ablate now with PF. Look on the temperature on the catheter. You can see a little bit of changes in color there. That's the minimal heating that you have. It's not thermal, but it reassures us that we're in contact because the lesion distance that we do is around 6 millimeter here, and obviously it overlaps with already injured tissue. So on our, let me just do another lesion. Actually, I think that's okay. Let's just go higher a little bit. Maybe we have a little bit of a gap somewhere there.
Mm-hmm.
This side is no potential, but the anatomical gap ablating.
Yes.
So not the electron guided, just connecting ablation tag.
No.
The disc of a green
Yeah.
ablation tag like 7 millimeters in diameter. Large electrode is 9 millimeter in diameter.
No good contact. No good contact. Push more.
Going to push a little bit into contact there.
This is perfect. No.
So you can appreciate
No,
how
no,
fast
push
it
back.
is. I mean, you do lesion very quickly, and
More is
then
not
you, even if you do
better
this
contact.
high density lesion string,
Not sure about
let's
the
say,
lesion. So máme fibrilaci komor. We have a VF. What is this? Máme fibrilaci komor. Můžeme bouchat?
Guys, show us for a second.
It's a VF.
there's a VF.
Hey, stop. Stop. That was arrhythmia.
See,
Was
there
this
was
ECG is strange.
No, I don't know.
Is that aberrant conduction or
It was noise. It was noise. No.
It was not. It was a bit.
Did you? It was noise.
No, it is a VT. And there's a strange ST elevation. So,
Can I see now?
no, můžeme dát atropin. And we have a 12-lead ECG.
No, it was an arrhythmia.
Já nevím, jestli miligram atropinu mám.
Can you scroll back, Wojtek? Can someone scroll back on the Pruka?
So this is a spasm or something. It's getting better, the ECG. Just hold on. Můžeme dát nějaký léky teda na... No, není tam žádný. So the ECG is getting normal. CDST.
Can you update again, please?
Můžeme dát ten atropin, teda určitě. Už tam teď to začalo něco dělat. The ECG is normalized now.
Don't really clear what happened to us
No.
here.
So you have ECG from that period?
Let's see the initiation, please. Can you go to the initiation?
Can we go to the left, to the review screen, to the left, to the left?
Left. A
You
little
can
Left.
show us the review screen,
Left.
what happened.
Review screen, can you show the review screen?
Go even. No. It's not a bump.
Can you go to the start of the elevation? Is the elevation? So it was a transient event. It took about 4 minutes with no clear cue. So this is the start, and there's a C1148 with unexpected.
And can you update now, Wojtek? Let's see what happens.
Now it's good. Now it's back to normal. Can we update? You see the ECG is normal. We gave some drugs because we had a hypotension, so if this changes on the ECG, so now it's a little bit faster response, but
Yeah, I must say I'm very surprised because
Yeah,
I
yeah.
haven't seen something like this before.
no, we haven't. Maybe wait.
Can we see the posterior wall?
So it was a transient event which lasted about 3 minutes.
but then it's real.
So probably a spasm or
Yeah.
something.
What about there, Wojtek? Let me see. That looks like in a gap area.
Okay, so I see that you are close
The way
to
between the applications.
finish the circle.
We are going to finish the circle now. I think we have a couple of more lesions here. And then we can talk about, try to evaluate what really happened there.
And it will continue with box lesion, yes?
Yeah.
Okay, so
Do you have a little
Any
motion there or
questions?
something? Or no?
this is obviously a little bit more time consuming
Can I
than
see the,
just a single shot, but it's on the other hand, it's very versatile. So you can do any line, you can do mapping, you can see the anatomy.
Not you, wait, I'm sorry. Peter.
So
Peter, can you
it's
show the eyes again? Where the catheter is?
it's a different system. This one is more universal,
Okay,
which allows you to do practically any ablation in atrium.
Okay, so the vein is isolated. Let's just see the vein, please. The electrograms in the vein. So there's no electrograms in the veins.
They are dissociated.
Let's see.
See, this was.
You have dissociate potentials in the distal electrode, the top one.
Can we see signals on the screen?
We can pace because the patient
Running
is still in an
signals.
arrhythmia.
So you
I think we
see
can
that-
do the posterior wall probably now.
Okay, so you have about, I would say, 6-8 minutes to show.
Okay, so maybe we
at
can do the
least.
posterior wall in the meantime, and we'll use the.
So
And then if the patient doesn't convert to sinus rhythm or to an atrial tachycardia, we will cardiovert
So
him
you see signals
and try
here
to induce.
after application. They should be diminishing. Oh, this is sorry. This is probably coronary sinus. But here we see, yeah, here we see there is no signal already. Can we have now a running screen with signals? It's after application, it's basically empty.
No, even before application.
No, I think that was already repeated.
Okay, let's look higher a little bit on the roof there.
So that's a superior line.
We'll do like a. Very good contact. Let's see. I think that's a better contact, this lesion.
So before this spot, no potential.
Yeah, because they are close to
think
the
the
previous
posterior
line.
is,
So if you are
Isolated by now.
close to previous line, there is this collateral, how you call that?
The reversible, whatever was done.
reversible
Hyper.
damage.
Yeah.
You don't see the signal, in close vicinity of previous lesion,
Yeah.
but it doesn't mean that you should not ablate on that area. So we just go visually
Make one
to
more lesion
overlap
here.
and cover all these areas. Something what we do with RF anyway.
Because you were far away from the right.
We don't leave any visual gaps.
And the posterior wall, if you can look on the electrograms, there's no electrograms, there's not even
This
dissociate
is now in the
potential there.
posterior wall, as you can appreciate, and there are no electrograms inside the box. And then
posterior
when we
is
will have
isolated.
sinus rhythm, you can pace from this catheter, and from this
Right.
electrode. And
We
then
back
you can
in the right veins, which also look, left veins looks isolated, and the right veins,
isolate.
there are still dissociate potentials there. So maybe you can go to a different lab, we'll assess what's
Okay.
going on here, and you can come back to us after we cardiovert the patient, and we'll do a mitral isthmus line. Is
Okay.
that okay?
Yes, indeed. I think we have now,
Very good.
Peter Neuzil wants to show a pre-recorded case. Is that right?
Yes.
Okay, so it's yours now.
So, dear friends, I prep one of the case I was discussing during my presentation. Can you get the screen with the movie? Perfect. Okay. So I will be the main screen. Perfect. So I will be showing you the case we use for the bipolar biphasic unipolar focal catheter using Egf Map system. Actually, it was recorded probably like, December, November. So this is a guy, 44 years old, with proximal atrial fibrillation. And again, as we have everything not clear, so actually it was planning to get proximal atrial fibrillation. And when the protocol is open for another lesions, not only PVI, so we got what we got. So you will see very clearly that it was not clearly proximal atrial fibrillation only. So ablation strategy is to use PFA only, no any other lesions with RF. So only PFA focal catheter, focal lesions. So this is starting in 9:23. This is actually on the top. You can see the actual timing. Now actually we are performing, or Honza Petru is performing contact mapping. Is not contact mapping, it's like contact mapping, creating the anatomy. Prior, we want to get the first lesions, and as you can recognize, the case was done not by me, but Honza Petru, Jacob Korud, who is a faculty, and Vivek Reddy as well. So now, after creating the anatomy,
okay.
Maybe we can start, yeah?
Perfect. Okay, so he's ready to start. So as I told you, we have a contact force catheter.
Patients in what rhythm?
Perfect. And he's preparing his lesion, but you need to understand it was one of the very first case, so he was very cautious to place the first lesion. So you will appreciate that he's going from the left, so it's the left side. And still, you can see that on the Pruka, the left top, we are pacing from CS. So the CS catheter is introduced. And on the top right, you see the fluoro with the lasso catheter in the left upper, and the contact force in the between in the central part of the screen.
It's better.
And be focused 3 pulses when he delivers. So he's ready to deliver the first pulses. Look at the Pruka, what's happening then.
Okay, so
after his Pruka moved to the right inferior, and now he introduced clearly some atrial activity. So by these 3 pulses, which I explained already during my presentation, 3 pulses, 1750 volts, and we have running some activity. Okay, so he will continue with the lesions based on the map.
Ablation.
And let's go for another 3 applications, 3 pulses.
Unlock.
He's not happy, it's not working. Perfect. So 3 pulses. So actually, in that respect, he will continue all the line as we are trained from our regular RF cases, based on CADO, based on NAVEX, based on arrhythmia. He's using edgeless, as I told you, the catheter, this contact force catheter fits to the edgeless sheet. Again, another 3 pulses. And please follow the time of the recording. Actually, the movie is 13 minutes. Okay, actually, if you have troubles and we need to speed up, please tell me, okay? Another 3 applications. And after that, I believe that he will speed up, or we will speed up the movie. Fantastic. So now he's very fast creating the line around the lefts. And after a while, when he's going to the anterior part of the lefts, it's interesting because suddenly, it will happen soon, after again the 3 pulses, even he didn't finish the circle. we would get something in the left upper soon, another 3 pulses. And look, the vein is isolated. So despite we didn't finish the circle, it sometimes happens. It's very unusual. Actually, on the ridge, it's a little bit like unusual, but it sometimes happens that we are not closing the full circle and we have isolation. So we need to finish the circle anyway. So despite actually electrical isolation is evident, so he will finish the full circle, and because he is tired, then he will be replaced by Jacob. So for right side, Jacob is doing his line, and look at the activation. So which is very fast, but actually after the left, the activation of arrhythmia actually changed and stabilized. So cycle line went longer and stable. Okay, so from a little bit organized or disorganized atrial activity, now it's happened to be organized activity. Okay, you can see that clearly on the right inferior live Pruka screen. And now Vivek is not happy about the atrial activity and actually the status. So he will get soon for the procedure. So after the right side, left side isolation, they started to map the atrial tachycardia, to have entrainment. So to decide which kind of lesion they would put, and actually for sure they clearly decided that you will hear it, like probably will be hearable, because actually it was clearly by entrainment.
Yeah, that looks good. I don't know. Mitrismus? That was mitrismus, yeah.
Okay, so it's mitrismus. So he decided for mitrismus, and on the left upper screen you can see the good technique how to deflect the edgeless catheter and actually to get really good contact with in the position of the mitral isthmus. So actually, what I didn't mention, and I mentioned during my presentation, as you can choose like the pulses, number of pulses. So these 3 pulses, when you are going closer to ventricle, so we didn't know because they were like really very first cases. So we decided when we are close to the ventricle, left side, right side, to get single pulse. Okay, so now clearly the activation of the atrial tachycardia changed. The sequence is changed, and after finishing this mitral line, they tried to get entrainment, and I hope that it will be soon again faster. Yes, it is, and after that he decided to go to the coronary sinus. I need to advance the thinking, so because I know the case, so I have advantage. Okay. So somebody mentioned that if we are using the focal PFA catheter in some other structures than the ventricles or atrium, so actually we can use even PFA focal catheter in CS, and it should be used a Farah pulse field catheter in CS as well. So he is trying to get the positioning of the catheter to the coronary sinus, which is happening right now. And look, and after just mechanical irritation, the tachycardia switch to sinus rhythm. So, but actually he needs to finish his lesion. So actually I hope that he will get some single lesion to add. The line to be solid, to be continuous. And
Okay, here we go.
I will a little bit
110
speed up the
Okay.
movie. So after this CS application, look, it's a one single pulse. So he decided why he is really like closer to the ventricle or in the coronary sinus. So we switch from 3 pulses to 1 pulse only. And he marked it on the mapping or the map screen, your mapping screen. You can see this CS application or single, and then for sure we continue with the lesion on the right side. So he will put soon the tricuspid
Okay, ready?
line, tricuspid isthmus line right now, so he's ready to go. So it's nothing too much important. So I will switch and speed up. Okay, the line is creating. It's all PFA, right? So it's all PFA and single pulse. So then he did the mapping of the left chamber to prove the isolation level. Electrical isolation level, so it's done, and you can see that from a 9 something, it changed like 10:58, so 11 a.m. and actually after 2 hours, less than 2 hours, he did this. Okay, so even mitral isthmus line is visible. The bipolar map, it's not activation map, it's a bipolar map, and actually we have some information about the procedure itself. So I will pause here. So it was 108 minutes procedure time, and based on the mapping, we could use just only 8 minutes fluoro time for 18 minutes total mapping time. So actually by mapping, we spent only 18 minutes, and when we distribute this over 100 PFA applications, so for PV isolation we spent 25 minutes, and you need to consider that it was like study, so we were really cautious and like first in man study. So it's really important to notice that it's not easy for us, and actually we place even the CS PFA lesion nicely there. So the system can serve something very interesting. This like field gating. So actually, you can visualize on this different patient. It's like a non-contact map, and on the right main screen, you can see this actually continuous lesion formation based on the mapping capability of the system, and I will just try to speed up. Okay, let's go here. So actually, it's clearly a visible gap in that case. It's a little bit different patient, I need to mention, okay, different patient. So based on that, they add some additional lesion. This visualization, this map is not regular part of the study, so we were not based on that, but we passively recorded. So actually, we fulfilled the gap in the line in this patient. So with this, I will finish my pre-recorded case, and I'm waiting for your questions.
Any question now for Peter?
As I mentioned, it was just biphasic bipolar. After this 14 cases, we did more like 9 or 15 cases. We did more like unipolar, but I'm not allowed to speak about the unipolar activation. Unipolar catheter.
So there is one question here.
Okay, Peter, Alan speaking. Hi. Just want to ask you, can you speculate? If you use Affera in this case, would it be sufficient to ablate the mitral isthmus only endocardially, or would you also expect the necessity to go to epicardial to the CS?
Actually, Alan, it's a brilliant question because actually we hope, and with Peppa and guys, Peter, Peichl, and Vivek here, and Honza, so we all together has an experience with the mitral line using PFA with Affera and using, high power RF with Affera. And believe it or not, it's really easy to do it. And actually, they will get, these guys, Acutus, they will get higher voltage soon for the little bit deeper lesion. So I hope with this improvement, which will be probably, I just speculating, just twice stronger, then I would expect that we really don't need to use any epicardial approach even for the mitral line.
Any other question? If not, Peter, thank you very much. We will move to another lab in IKEM, and then we come back to you after 20 minutes or so, yes?
And actually, we will show you the map we did after this.
Okay. Yeah, perfect.
Thank you. Bye-bye. Thank you.
Greetings from IKEM. We are here with Dr. Anic, and my name is Predrag Stojadinovic, and we will show you the case of persistent AF ablation using pulse field and Farapulse technology. So next slide, please. Here we have a 68-year-old female patient. She has a metabolic syndrome, she's obese, and she also has a coronary artery disease. And this lady had an embolic myocardial infarction at the end of 2020 when AFib was firstly diagnosed. And the reason for this embolic event was the thrombus in the left atrial appendage that dissolved on anticoagulation therapy. This lady had a electrical cardioversion. She got propafenone that was ineffective, and she now has a persistent AFib despite amiodarone. And recently she had an electrical cardioversion, so she's now in the sinus rhythm. She has a very high CHA2DS score, normal ejection fraction, and slightly dilated left atrium on the echo. As it was said, she's on amio. And let's move to the next slide, please. Can we show the next slide, please? Can we show the next slide? Okay. So this is a ECG on the admission. We see sinus rhythm. And the next slide, please. This is her ECG with AFib. Okay, let's show the eye screen now, just to show you the anatomy of the atrium. Okay, you see, if you see, so we see here a pretty small atrium with left common trunk, and the right-sided veins are pretty big. We measured like
2.0 is the right superior.
2 centimeters. Okay, and then we will show you the map we did.
Yeah.
If you want to overtake from now.
Thank you.
Okay.
Thank you, Predrag. So Predrag acquired the left atrial voltage map. The global voltage is preserved. We do have some area of scar tissue or fibrosis around the right superior. And then we're going to show you, we are able to record, which is typical for this patient population, 70-year-old lady, persistent patient, CAD. So do you see a map? So you see a map, and you see that we, on our anterior part, we could see some fractionation and fraction electrogram. Can we see the Pruka screen? We want to show you how does it look on a Pruka. So the Pruka screen. Here we go. Okay.
There is some delay.
So now you see the review screen. The review screen, not the live screen. Can we show the review screen on Pruka? If we cannot, so there are you see now, very fractionated electrograms, and during the CS spacing, it's even more pronounced, this delay. So we have some area that after the box lesion might be the perpetuator of some kind of perimitral flutter. So after we do box lesion, we're gonna definitely remap and then induce. Okay, so now we are ready we have ferrodrive sheet inside. We prepped and it's irrigated already the 35 millimeter Farawave catheter. I'm going to do our standard approach. We're going to do it under, so the hemovalve is submerged, the catheter structure is submerged. So while everything is submerged, I'm going to enter the sheet. And now I'm going to use this transparent shaft to see if there are any bubbles. If there are any bubbles, they're usually on the back. And you see, now I'm satisfied there are no bubbles. Okay, Predrag, please, can you take this away? Okay, we are going up. We're going up with an ablation catheter. Okay, can we turn lights off, please, a bit? Okay, now, idea, though we have common trunk, we measured, isn't it? Okay, yeah. Here. So let's stay there, please hold the wire. So our idea is to go there, and so we're gonna try, and we're gonna do our best attempt to, okay, let me go in a basket. So we're gonna do our best attempt to do this ablation integrated with the NavX. It's not a seamless integration. You will see that we're going to have to shut and guide off for each application. And okay, I like this. So Predrag, do you think I have a contact? I think we are in a contact. Of course, it's covering already the whole aspect. So actually, we are ready, not too much of the electrograms, but we're going to treat this. This trunk as a separate veins. So unguide is off. Thank you. Because one thing we measured 7 to 8 millimeters thick the ridge. We want to do more applications to this vein. So now we are ready to apply the first application site. First lesion on the LSPV. I see it on the floor right now. Good. We have contact. Everything looks good and nice. Yeah. I'm pushing maybe too much. Okay. So now, Pavel. LSPV, pulse 1, go. Okay, LSPV, pulse 1, confirm, deliver. LSPV, pulse 2, go. LSPV, pulse 2, confirm, deliver. Good. Predrag, please hold the wire. Okay, LSPV, pulse 3. You see that already on eyes that you are covering the whole trunk, but anyway, we're going to apply the regular lesion set. So after 8 applications in each vein, we're going to apply 2 posteriorly directed lesions. Go. This was what?
3.
Go 4. LSPV, pulse 4. LSPV, pulse 4. Okay. Okay, now we're going to do, let's go in a flower. Sorry, yeah, sorry about the wire. Okay, sorry. Keep it there. Okay, we go with a flower. Okay, good. So, Predrag, do you like it on ice?
Yeah.
Yeah, let's go. LSPV, pulse 5. LSPV, pulse 6 when ready. Yep, deliver. For the next set of pulses, I'm coming back also during rotation, but I'm going to do some anterior torque. Yep, so I'm counterclocking the sheet. Okay, LSPV, pulse 7. We are really hugging the whole... and this is good, because anterior, you see that the interior part is already inside. LSPV, pulse 8. And now, this is very important for our strategy of posterior wall ablation. I come back and we deliver what we call anchor lesion. I rotate and come back here. So this is LSPV anchor, and you've seen on fluoro that we're having good contact. Go. Observe on fluoro. So while having a wire inside, it serves an anchor lesion and ensures contact with that far structure, especially elongated LSPV, anchor, pulse 2. Okay. Okay, so now we come back. Sorry, Predrag. Let me try and cannulate the inferior branch. Okay, come here. Yeah, it is. You like this, Predrag?
Yeah.
I like it, huh? Okay, but I come back. Sorry, Predrag?
You want to make a basket?
Yeah, that's it. You're right. Okay, come. Sorry. Yeah, keep the wire inside. Sorry. Okay, sorry. Let me go in a flower again. We have to go deep in that. I like that. Sorry. Let me just cannulate the most inferior branch, huh? Sorry. We succeeded. Yeah, I like this. Why don't we keep it fully inside? Okay, this one. It's a, you see? Keep like this. That's fine. Okay, let's do this. I'm pushing too much, huh? You like this? Yeah, keep the wire.
Much better.
Leave the wire, leave the wire, leave the wire. Now we're fine. Now we are orientated like a hockey stick. That's fine. LIPV, pulse 1. See that we are hugging the inferior part of the trunk. We are very, I like this. LIPV, pulse 2 and ready. Go. Okay. Just don't keep the wire. Don't keep the wire. That's fine. I'm going to come back a bit. Rotate. Okay, like this. Sorry. Okay. Let me adjust this. Actually, I don't need wire right now. But
well, it looks that you are covering a little bit of mitral isthmus based on signals, at least.
Don't you worry. Don't you worry. Don't you worry about mitral isthmus.
Okay.
I think that I think you're right to be concerned, Professor Kastner.
Yes.
You're right to be concerned right now, and that's why I'm going to go back in the flower, come back, and then let's try and cannulate the inferior. Stop. Now hold. Okay. Let's come here. Okay. Good. We're going to stay in a biscuit right now. Okay, I'm going to reload here. Let's go here. So LIPV, pulse 3, go. Now we are kind of biscuit. You see that we are having contact with the inferior rim of the trunk, which is very important here. LIPV, pulse 4. Okay. Okay, we come back in the flower. We advance. Okay, I like this. You see now that we are, I like this. We are keeping LIPV pulse 5. It's very nice to have eyes, and it's very important to understand you have contact here. LIPV pulse 6, when ready. Go, 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 go. Thank you. Okay. I come back, I rotate, I counterclock the sheet. Okay, good. LIPV, pulse 7. You see an eye that now we are hugging right. And I'm counterclocking the sheet to embrace more of the anterior part where there's a thick ridge. LIPV, pulse 8. And then we are ready for LIPV, pulse 8. And then we are ready for anchor. Good. Okay. Okay. From here, we come back, we rotate a bit, flex the catheter, and direct it toward posterior. Okay, Jan, are you ready to take? Jan, are you ready to take the shadow of the? So this is a LIPV anchor, pulse 1. Jan, can you show us the image from a superior view? Go. Yep, this anchor. Now you see that we are hugging more of the posterior wall. Thank you, Predrag. You see it nice, yeah. And LIPV anchor. Good. Thank you. Thank you. Thank you, Jan. Good. Deliver. Okay, we're down with the left side. So what we're going to do now, let's go to AP. Okay, that's fine. So I'm going to stay. Okay, I'm going to stay in flower configuration. Yeah, thank you. I'm going to stay in flower configuration. Retrieve the wire. Let's flex the. Sorry. We have to see the, yeah, this is it. So where we are flexed, let's go like this. Now we are likely, okay, I'm gently advancing the wire.
Right inferior.
We are right inferior. So Predrag, how do you like it? See it nice that we are hugging the septal part, we are hugging the posterior part.
Yeah.
Okay, but actually I like it. Do you see, show me, please let me eyes. Guys, do you see that we are hugging the, very nice. So let's start. You see here? Yeah, let's go. Right inferior, yeah, right inferior PV. So we're gonna stay in flower and first for application flower. Right inferior PV, pulse 1. Let's see what happens on, go. So we do see phrenic nerve stimulation, because obviously there's not too much paralytics being given, which is fine. And I like the contact. I like the contact. You see the posterior contact, septal contact. Nice. Go. Right inferior PV, pulse 2. Deliver. Okay. Now I have to relax my sheet. I rotate a bit. Good. Let's do this. Right inferior PV. I'm more posterior directed. Go 3. Good. Now I'm directed more posteriorly a bit, and then we go. Okay. Right inferior PV, pulse 4. This is not anchor. Okay. Okay. I'll try and go in a biscuit. Come back a bit, huh? Okay. How did it look? Oh, it's nice. It's but
I would a little bit sheet.
Thank you. Let's do this then. How do you like right now? Sorry, show me the septal part. Oh yeah. Okay, let's go. Right inferior PV, pulse 5. You see how we embraced the both parts, septal part and posterior part, huh? I like this.
Yeah, it's moving.
Right inferior PV, pulse 6. Ice is very useful. I wouldn't say mandatory. Go. Thank you, Paul. Okay. Come back. I have to come back a bit. Rotate as much as we can. Good. Let's go here. Now I'm definitely touching the septal part. Right inferior PV, pulse 7. Very nice. I like this. And right inferior PV, pulse 8. Now, go. Go. Thank you. Okay, now we're gonna let's stay in AP. Are we in AP, Predrag? Okay. Now I come. Okay. Now I come in the flower. Come back to flower. Come back, and we go. This is nice. This is nice anchor to the right inferior. Predrag, you should see me that I'm more, posterior directed. You see, that's nice. Okay. So this is the right inferior PV anchor, pulse 1. See on fluoro. We like that. Good. There's no phrenic nerve stimulation right now because we are getting more toward the posterior. We have nice anchor. Yeah, based on this, there's no too much work. Okay. Across the wall. Right inferior PV anchor, pulse 2. Okay. Go. Go. Good. Now, while we are still in flower, let's go in the upper vein. Sorry.
We are there.
Sorry, but just let me try with the wire. Actually, I'm not using.
This is inferior.
This is inferior branch.
Superior vein.
Superior. I like that. I like that. That's no problem. So the first application, the right superior, is always in the flower. Let me do this. I want to rotate more. Just I'm heading. I'm trying to find my.
It goes to the inferior branch of the
inferior branch.
Vein.
Yeah. Okay. So sometimes when there is a big vein, vein, you wanna do. Are we inside? Yeah. Yeah. We are a bit inside. You see. We are a bit inside, so we have to rotate. And I will intentionally misalign the stuff, like this. Now inside. Okay. So it's a big vein, 20 millimeters, and the device is falling. Okay, I like this. Now we're more. Okay, sorry.
In the inferior now.
Yeah. Just let me just go up here.
Yeah, that's much
okay.
better.
Keep the wire, please, Predrag. Okay, now I have to play with the flower. Come back. It's not that comfortable. Okay. So now what I will do now, sorry, Predrag, I will come back. Let's do this. Oh, sorry. No. Sorry, it jumped out. Yeah, like this. I wanna stay. Are we up there?
Yeah, we are going to some inferior branch of the.
Inferior branch of the superior, which is not bad. But this is not okay. Let me come back to the flower, and I will show you. So sometimes I don't wanna. So if you don't have ice, you just apply. It's not a problem for you. But if you have ice, then this. How do you like this? This is still the inferior branch.
This is superior vein.
Yeah, I was able to get to that more anterior.
There is a pulmonary artery, so this is superior vein.
It is. Predrag?
Yeah. Maybe if you make a
sorry.
basket, you will go in.
No. The trick is when I'm in a flower, I wanna get in the most superior branch. because we are able to do that before,
Yeah,
like this.
now you are
Okay.
there.
And
Okay,
first we're going to apply segmentally. So we're going to apply. You see that we have a good
We are
contact with the
covering
upper.
the upper part,
Yep.
yeah.
So let's do segmental part because it's a big vein. It's going to jump in. So we don't. So let's go here. We go for the right superior pulse 1. And this is anteriorly and superiorly directed application.
Can we see
And now
signals
we are-
on the
we are
main
def-
screen?
There are no signals actually.
Yeah.
Well, before you apply.
Right superior
Yeah,
PV.
yeah.
So what I'm going to do now, keep the wire. So this was the first set of lesion. Now I'm coming down, rotate, because I want to hit carina like this. Go this. So we are doing segmental part. Go. RSPV, you see? We are now touching the lower part. RSPV, pulse 3. So we're going to do 8 applications in flower, and it's like segmental approach, like you're doing with choir balloon, with the trunk, whatever. Because sometimes when it's too big, you better RSPV, pulse 4. Okay? So now we are traveling. We delivered anterior, we delivered lower. Now we're coming down. Actually, I want to come down. Yep. Actually, I know my wire is in, but guys, I have to take care about, I want to take care, no, it's too much down.
Okay,
So I'm
I
taking
think,
the
Ante,
segmental approach.
we will move to another lab and you will show us
Good.
final result later.
Show us the
okay?
lesion set.
Can we
that's
switch
fine,
now to
thank you.
Homolka?
So, Peppo, we are live? Super.
Don't say that word.
Okay, so guys, so we Honza map the left atrium, and here's a pentanav in the center of the scar. Did you pace it already?
Yeah, we can pace it right
so,
now,
so
but
we
there
are
are no
ready
signals.
for stimulation from the scar. From the
Yeah,
scar,
so no
from the
signals,
posterior wall.
maximum pacing from posterior wall. There is nothing, no capture. So I can move to all parts of the left atrium. So now I'm in the stop pacing. So this is left common. There are some dissociated signals sometimes if I do some maneuvers there. So maybe you can see.
And actually, we converted the patient to the sinus. Actually, he several times went to atrial fibrillation again. So after this, he's really stable in sinus rhythm right now. Okay, so it's a very important mark. And actually, can we show them the improved tagging on the CT, because it's proper tagging. Because we changed the tagging because properly, it was done properly right now, okay? So this is really like we are doing in the usual case, okay? So can you move, yeah, perfect. So can you move right and left to get them idea? Perfect, okay? Go tilt it down. Okay, so in the roof, so actually on the left, we try to get on the roof, and we really succeed. And actually, when you look at the posterior, give me the posterior wall again, PA view, and match the PA view with the Cato. So actually, we really match in the the lesion formation with the so-called like scar formation on the posterior wall. So actually, I am very happy with this. And with this finding, I think that we can finish the case, and we can thank you for the patience here. And I think we add some more information, and I follow the Ante case in your lab. So I think that we can give the people idea how to perform the PFA with far wave catheter, even on the posterior wall.
Thank you very much for this nice demonstration. I think it was very instructive, and everybody is persuaded that there is complete blocks like Cobra, working Cobra ablation, which is not usually the case with surgeons because there might be some gaps sometimes, but here it's totally destroyed in the whole area, not only pulmonary veins, but also the whole posterior wall. So can we maybe now switch to IKEM first lab, where Peter Peichl is?
Okay, we are here. Okay, so we have a running atrial tachycardia, and Elad will explain what was happening.
So guys, let's just go back to where we left off, and we'll explain what happened. Voida, can you show the left atrial map?
Can we increase volume?
Can you hear us?
Yes.
Okay, so let's just see the left atrial map. So while you were watching us, we isolated the right superior vein and we did the posterior wall isolation. But as you remember, during ablation of the right pulmonary veins, we had a transient ST elevation, and this transiency lasted for like 4 minutes. We don't, and then the patient became stable again. We gave some pressure support for like 2 minutes, and it all came back normal. We don't really have an explanation why it happened. We have to think about it more, but I can tell you that's the first time that we ever saw something like this. Now, it was not associated with delivering energy, so it did not happen just after energy delivery. It could be that, but the territory of this looks like the RCA because the ST elevations were seen in leads, mostly in leads 2 and 3, more in 3 than in 2, which suggests what we typically see with like an air embolus or something with a proximal RCA. When we looked on ice on the left ventricle, we did not see any stunning that often you see with an air embolus. So
there's usually also staining of the myocardial wall with a kind of microbubble, so it's really white because the air is echogenic. So we didn't also saw small bubbles in the aortic arch, which is always the case when you have some small bubbles. So it could be, but
it could be bubbles. It could be coronary spasm. It could be many things that we don't know because we've never seen something like this before. I think that's important to
very transient,
emphasize.
and then it disappeared. And we are here in the case. The patient is stable. Has a.
So this is the voltage map post-isolation and the activation map, and I think you can see this on your monitor. Voida, maybe you can just rotate a little bit the map. This map was done during CS pacing. You can see that the veins there is entrance block into the veins and into the posterior wall. Okay, we converted the patient to sinus rhythm as he was in atrial fibrillation. Did the activation map and then did a sequence of pacing to induce an arrhythmia, and we did induce this tachycardia.
Maybe you can show
Can you switch to Pruka? You can see
online. Can we go for online screen?
Online screen. Okay.
What is this? This is not us. This is us. Okay.
This is us. So you can see the tachycardia. I think the cycle length is just shy from 300 Voida. Is that right? Yeah. 285. We started by mapping the left atrium. Let's see the activation of the left atrium of this tachycardia. You can see this on the left. So if you can see the propagation.
No, you don't see them. Can you show? So
they saw it for a second.
Okay, now do you see? Maybe you can. Okay. Activation of the map on the left.
Okay, so you can see the focal exit from the right septum, right superior, right roof septum, and we can rotate all the way, and you see that it collides on both sides of the mitral annulus, so that suggests that the tachycardia is not left atrial, it's exiting into the left atrium from the right atrium. So we pulled the catheter into the right atrium and made an activation of the of the right atrium. And can we play this propagation? Maybe you can spread the colors. Yeah. So can you remove it?
This is ventricle already.
We have some overlap of ventricular electrograms. We'll take them out. But basically what we found was a counterclockwise.
Clockwise
tricuspid annular flutter. The patient did not have it before, but we induced it, and we are going to ablate it. Any questions, Joseph, before we move on about so far what we have done?
Any question? I think it's very instructive again, so everybody can follow what's going on. You see, again, isolation of the whole posterior wall, all pulmonary veins, then typical flutter with clockwise rotation. And now you
Can
will
we
see.
cut out the, this is annulus, so can we cut out the annulus like this?
We will see now
So
the
it's much
ablation
larger.
of cavo-tricuspid isthmus.
Yeah. Voida, can you show us two views for CTI line? So we would be happy
Yeah,
if
it's
you can
clockwise,
see
yes,
also our
that's what we
eyes.
said. I said clockwise, Father.
Okay. Can you please show to the audience
it's
the
too
ice
far.
image? I would put the ice image and on the other side the
Can we,
electroanatomical map.
reverse, because I don't know who did this, but we
Actually, you know what? You don't need the electroanatomical map. Can you
We
show
use-
the live Pruka and the ice? Right? I think that's
Yes.
what we need.
Can we
Live
reverse
Pruka and
the ice image? So that here is inferior, here is superior, not a vice versa.
Maybe you're fine. We can start here.
Okay.
You see the ice, you see the balloon. It's
Okay,
you see-
this
you
is
see the ice, you see the-
isthmus. Or you have to look like this.
Right.
No, dobrý je to, takhle to nechte už.
So if you remember the isthmus from yesterday, the CTI from yesterday was half the length of this isthmus.
quite long.
But you can see also the large footprint of the catheter, and we assume, like, if you calculate it, you probably have 6-8 lesions here to cover the entire CTI.
One comment about the ice image, it's flipped like they use in Philadelphia, when probably because you are used to it. So this is not normal what we are used to. It's just mirror image. So it's just what is on the right hand is usually what we see on the left hand.
Yeah,
But
if the audience wants, we can flip it.
maybe for the audience, if we can flip it, maybe, okay, this is what we are, if
Yeah.
those for the users maybe found this
That's
kind
how
of
normal
more-
people look. Yeah.
Yeah.
And we're going to use RF to create the CTI. We can do it with pulse field, but we showed you most of the case with RF.
Okay.
So we'll start with. So we're going to apply the first lesion.
Jsme připraveni stimulovat, jo?
We have some. Okay.
So wait a bit.
And you can see the whitening. You can see the whitening on ice. And I think the cycle length a little bit prolongs. Still the same?
But it goes under 2 lesions and we're done. I'm pretty convinced and confident.
So
Okay.
we are more or less in the middle of the isthmus now.
Middle?
In the middle of the isthmus, of this relatively lengthy
That is
isthmus.
IVC would be here, so it's another 1 or 2 applications, I believe.
Okay, finished. Can we pace?
You see
And
it's
the
already
tachycardia
gone.
terminated.
It doesn't mean that there is block.
And it's
but-
block.
Oh, it is. So.
We'll
Pull
do
back,
another
pull back.
lesion. Now you can
There
see
is
the
white.
catheter now just sitting on the IVC.
But it's blocked, as you can see the
tricuspid,
signals are split it.
Yeah, there is white split. So 1 more lesion, and it's done.
I believe we can now map just to show you how speed is the map of the...
Now I'm just going to go a little bit lateral to the line.
But also do the map. Just show the audience how the quick No, yeah, you can, but also do the map during
But
the
we
CS
have
pacing,
to move
please,
very
because I
soon
believe-
to the other lab. So if you
Can you
have
show a
something,
vector? Can you show the
if you
vector,
have
please,
something
Voita?
important to show, it's
We
your,
just want to show you one little thing, and
Can we paste CS? Yes.
can you paste the CS? Yeah.
Yes, that's the vector.
Pasting CS. Okay. You can see the vector on the catheter coming
Can we
from
see the
lateral.
maps? Can you show the large screen, the
Large screen
maps
for-
of the
for
Afera
map.
system?
there is this beautiful vector. Shows you if you
Going
have block.
from lateral to septal.
Can we maybe move to the other side just to
And
show?
now I'm going to move to the septal aspect, and you see that the vector changes its position going to the line. So there is block across this line. I think, Joseph, that's conclude what we have to show you. So if you want to move to another lab, you
Yes.
can, and we'll be happy to give you follow-up later on too.
Well, okay. Thank you very much. I think it was
Thank you
again
for having
nice
us.
demonstration. Let's move to Homolka, the last case.
So the next case is another AFib patient for electrographic flow mapping and extra-pulmonary vein source ablation. Here we have a 66-year-old male with CHADS-VASc 4 and history of diabetes, chronic kidney disease, and ischemic heart failure with chronic ACD occlusion. There was a right ventricular transmural scar on magnetic resonance. On echo, he has a mildly reduced ejection fraction, moderate functional tricuspid regurgitation, and enlarged the volume of left atrium. He has a history of long-standing persistent atrial fibrillation since 2017, and his symptoms are exertional dyspnea. He's anticoagulated, and he's on chronic amiodarone treatment. 2 days ago, we performed an optical mapping using the Topera basket, and this flow activity mapping demonstrated very nicely and repeatedly stable arrhythmic drivers in both right and left atrium. Here you can see the 12-lead EKG from yesterday's admission. We see atrial fibrillation and inferior scar, and this is the enlarged left atrium.
Me? We certainly can't hear him. Joseph? Okay. Joseph, can you hear me?
Yes.
Okay, great. So, okay, so just for a time check, how much time do we have to finish this?
About half an hour.
Okay, perfect. So, you know, as you heard, so this is a patient with persistent atrial fibrillation. We did mapping in this patient 2 days ago, which turns out to be pretty interesting, and we'll show you that in just a minute. I just want to give you a broad strokes of what we're going to do, because it's a bit complicated. And then I'm going to have, and then Toshi is going to move forward with the PVI part of the procedure while we talk about the technology and what we're going to do, okay? So let me give you broad strokes, and then we'll get into the details. So in broad strokes, this is a patient, again, who has persistent AFib, as Pavel said. Our goal here is to isolate the veins and then use EGF mapping to look for residual AF sources, and then we'll try to target those regions, okay? A region or regions. Now, the way we're going to do the EGF, we also did a baseline EGF map, and this is for, you know, for our interest. Technically, you don't need to do a baseline, but we did a baseline map. Then we're, Toshi's going to do PVI with Farapulse. Since you've already seen 2 or 3 cases with Farapulse, we're just going to do that sort of in the background. While he isolates, I'm going to just explain the mapping system and the mapping technology. And by the time I'm done explaining, Toshi will probably be done with this PVI, and then we'll look to see what's actually residual, okay? So can they see the presentation? Well, actually, no, we'll show. So if you look on the fluoro, what we have right now, so, oh, you took the basket already, Toshi? Okay.
Yes.
So you have the basket catheter. We had the basket catheter, which is just the regular Topera basket catheter in there just a few minutes ago. Show them the Cardo screen, please. And just, if you rotate the Cardo, show like an AP view on the Cardo screen. And you see that's where the basket was sitting, and you'll see why it becomes important in just a minute. So Toshi just took out the basket, as you see on the fluoro. Mm-hmm. You can go back to fluoro, please. So he took the basket out, and then he put the pentaspline pulse field ablation catheter in. So that's where he is right now. The other catheters that are in, we have just the CS catheter and ICE catheter. So at this point, Toshi, why don't you go ahead and start doing the PVI, and I'm going to explain what the system. So,
okay. So we can learn about the PVI.
You can put Toshi sort of in the background, and I'll go through the slides here. Okay. Yeah, no, I'll do that. But in the other screen, don't show me. There's nothing to see. Show what's happening with, you know, the fluoro or something, so that people can at least watch the Farapulse going on.
Perfect.
Okay. All right, good. Okay, so these, I'm just going to go through a few slides here. So I think before we start with what is EGF mapping, let's talk about where we came from in terms of phase mapping.
There you go.
So as you know, we've had a couple of systems with phase mapping. One of the issues with phase mapping is that the algorithm is specifically looking for rotational, well, specifically for rotors. And this is a problem because there's the problem of false positives if there's low sampling frequency. The graph on the right is really, I think, a very useful one. So what you're seeing here is this was a study that was published a couple of years ago where the investigators just, they put different density of electrodes. So on the bottom, you have this complex thing with whatever, I guess 10 electrodes. On the top, you have just 4 electrodes. And then they artificially, and then they just created noise. And then they put these electrodes. And what it was asking was, can you identify rotors in what was essentially noise? And what you see is with the low density ring, the 4 electrode ring, you have lots of times when rotors were identified, even though it was all just noise. So it's when you have high density that you can get good data. With low density, you can not get good data. So that's one of the big problems of phase mapping, is the possibility of false positives with low sampling frequency. So how does EGF mapping differ? Well, it's actually based on principles of optical flow, and we'll talk about what that is in just a minute. It's a technology that uses basically near real-time visualization of the action potential flows, and it does that because we're using a sort of a global mapping with this basket catheter. It also has the ability to differentiate between active sources and passive rotations, and we'll talk about that. And it appears to be clinically relevant. Now, obviously, the clinical studies are still being done, so we can't say things definitively, but certainly it's promising. What does it mean in terms of estimation of optical flow? Well, in the field of computer vision, this is a problem, and basically what we're talking about is trying to track pixels in a video. And here you see an example. So on the bottom, the computer is visualizing this motion based on these colors. And the color on the red means going to the right, and blue is going to the left. And it turns out that tracking pixels is not an easy thing to do because objects sort of change. They're just not easy to identify. So this is an important issue, again, in terms of computer vision. So there are strategies that have been sort of perfected of trying to estimate optical flow. So here's an example. Look at this blob that's just sort of going round and round in a circle. Now this is pretty easy to identify. This is not terribly complex. But let's add some noise. You can sort of just make out a rotation in the center of that if you add this noise. And this is what the optical flow algorithms are able to do. They're able to look at the different vectors, looking at flow, and then based on that, identify areas where you may have sort of rotational sources. Here you add even more noise, and still you're able to identify this. So you can imagine using this kind of a methodology that perhaps if you have EKGs, perhaps we may be able to identify sources amidst the rest of the noise of atrial fibrillation. At least that's the theory. So how do we map the cardiac action potentials? In broad strokes, we take a basket catheter. It was the Topera basket, which is all we have available, though the company is actually making their own basket catheter, which seems to be much better in terms of not splaying the splines. But again, today we're just using the Topera basket. Then the electrical potentials are evaluated, the flow fields are calculated, and then we end up with these EGF flow maps. So what you're seeing here is a 2-second sort of depiction of the flow, and then what you see here is sort of a statistical understanding of a full minute. So if you have 2-second recordings, you take all the 2-second recordings and you put them together, then, for example, that red hotspot will represent an area where there was this rotational activity more than X% of the time. So first, the EGF map, you take the unipolar electrograms, basically unfiltered, you remove the ventricular signals, the QRS segments, and then the signals are normalized prior to processing. Then there's certain assumptions that are made. One is that the electrode spacing is smaller than the AF wavelength. The other is that, and then over the 2-second windows, there's a spherical boundary conditions that are put, because obviously this isn't just a sheet, it's a basket. Then this algorithm, the Horn-Schunck algorithm, converts this time domain data into the space domain, and what you're seeing there is sort of a single 2-second representation of the vectors, the flow vectors. And then you take all these 2-second vectors, you put them on top of each other, and you have a statistical understanding of where are the hotspots. So let's just take a look at an example. Oh, and actually, this is another important thing. If you look right here, for example, where you see the yellow dot, all the flow is heading away from that. So that is potentially a source. On the other hand, if you look at the bottom, you see flow heading toward that location. I'm going to play that one more time. So that looks like a passive rotor. So if activation is going toward it, then that can't be something that's driving this, this activity. So this is what we're going to see. On the left, you see a 2D snapshot, which is basically, again, a 2-second window. The middle is the same thing. It's just shown as if it's a full sphere as opposed to splaying it out flat. And on the far right is a summary map. And again, that's a summary of all the 2 seconds over a course of a minute. So in that, for example, the big red dot represents an area that the software says is a source, because it's there more than 26.5% of the time. And that seems to be the number that's relevant in terms of identifying a true source. The white dot, by the way, is just a passive rotation. On the bottom, those are the individual segments. So if you want, you can look at each of those individual segments to see what's going on, though in reality, what we end up really using is a summary map. Yep. Here's another example. And the point here is that sources can switch on and off. So for example, here, that's, again, a 2-second map, and you see a source there. But then look at a little bit different time. There's a source down here, but not up on top. So on the very bottom, in the summary map, you can see 2 small red dots. And those are the 2 different sources. So you can imagine from something like this that you have to have some sort of global mapping approach in order to see these things. Okay. So let's come back to today's patient. So as you heard from Pavel, 2 days ago, we had mapped this patient. That was the position of the basket catheter. And you can see a source up there. Let's splay it out. So this is actually the source. You can see on the left a static map, and on the right, you can see the activity is heading away from this. Now look at this. If we look at the individual electrodes, 1, 2, 3, 4, 5. So we have a source going around a circle there. And then we actually look at the electrograms, the 1, 2, 3, 4, and 5. You have you can actually see the unipolar electrograms to help you sort of confirm that this does seem to be real. Now that was 2 days ago. Now let's switch to what we have today. So let's switch to, let's show this Egf map. Stefan, let's go to the Egf map, please. Can they see it or not yet? Okay. So just before you guys came on, we put the basket in the left atrium, and this is what we saw. So if you look at this map, can you show them this? Okay. So let's look at this one right. Point to this one right here. So this one right here, the middle one, that's just one of the 2 seconds. So if you look on the bottom right here, this orange segment here, I don't know if you can see that well. This is one of the 2 segments. So when we click on this, we see that. Let's click on another one. How do you do that? Just click on it? Okay. So if we go to here, for example, there it is. Again, it's this one area that's hot at this 2 seconds. By the way, if you click over here, where is it? Here. How do you do that? Try this one? Okay. So if we click on this one, for example, we actually don't see it here. And that's the point here. Sometimes it's there and sometimes it's not. You really have to look over the whole 60 seconds. This one, when you average all of them, ends up being a hotspot. So on this far left summary map, this is an area that was interesting. Now, what is this area? Then we go to the Cardo map. So let's go to Cardo, please, and show them. Can we show okay, good. And then if we can rotate that Cardo map, please. Let's get the basket.
We are in position.
Okay. So if you look over there, no, show the left lateral. That little circle is the location where it was active. Okay. So this was again and this is just now, right?
Yes.
Yeah. So this is the same location, by the way, that we saw 2 days ago. So compared to 2 days ago to now, we're actually seeing the same location that appears to be the source. Yeah, please go ahead. Yep. So we just did the PVI, okay? And Toshi's done, as you saw him rotating and everything. So now what we're going to do is put the basket catheter back in. And you can show him fluoro too, please. Yeah. We're going to put the basket catheter back in, and we're going to do another acquisition. Hopefully this is somewhat clear what we're doing. So you can see the patient still in AFib. Can they see the, hopefully they can see. Just show them Stefan, show them oh, they can see the map up there. Okay, good. Okay. So let's see what we see here. This is going to be interesting. So, any questions so far, Joseph?
Well, it doesn't seem to be the case.
Okay.
I think everybody is interested what will be the outcome.
Yeah, so am I. I'm very interested. And just to be clear, look, if a source is here, and this is the dominant source, and let's say we ablate it, frankly, the AF may not terminate immediately. It may take some time, or it may not terminate. And what we'll end up doing is basically we're looking for all the sources, ablate them, and then with cardivert if the patient's still in AFib. Now, you can say, well, how do you know it's going to work? Well, we're doing obviously a clinical trial called FLOW-AF, which is an ongoing study. And the trial is actually a randomized trial looking at this. Okay, so what do we have?
What is it comparing with the trial? What is a comparator?
Yeah, let me show you the trial. Actually, can you show them let's show the presentation one more time, Stefan. While we're doing the acquisition, let me just explain what the study is going to look like. You got it? Are they seeing it? They're not seeing it yet. Okay, thank you. So the randomized trial, so basically we're looking at patients, and this is at 4 centers, as you see here, at Homolka Hospital, Erasmus Medical Center in Dresden, and in Hamburg. And again, we're looking at patients who are basically redo patients, so patients who've had an ablation and continue to be in atrial fibrillation, persistent patients. So if the patient is in AFib, if they're not in AFib, that is, we induce. If they're in AFib, then we do a baseline Egf map.
Impedance.
Then we do a PVI touch-up if required. Then we repeat the map, and we look for sources. If there are sources, then we randomize to either the control, which is we stopped at the PVI redo, or we add this Egf ablation.
Zero, Stefan.
And then we see what the outcomes are. So the question is, does Egf ablation improve outcomes in AF redo patients who have persistent atrial fibrillation?
Zero,
so
please.
that's the design. Okay, so right now, what are we doing? We're still acquiring more? So, okay. You know, one of the issues is that the Topera basket is not perfect, as we're all aware. And because it's not perfect, what we have to do is basically take the basket, put it in one position, and sort of move it over to this position, and then get a couple of different recordings. So while I say it's global, it's probably, well, let's say largely global, but not exactly completely global.
So we're ready to ablate.
We're done? Okay. So now we're doing the analysis here? 30 more seconds, okay. So it's being analyzed in their software, and in just a minute we'll see what it shows. Let's show them oh, they see the EGF screen. Okay, good. Okay, let's see. What size gloves are these? Oh. Okay. Wait with breathless anticipation. Do we have a different position? Well, it's pretty good. You notice, by the way, that because the system is not linked to a mapping system, we're recording on Cardo to look at the location and then doing this. It's obviously a bit cumbersome. The company is working on making this a complete solution. Okay, here we go. Do you guys see that? What is that? Can you show me? Is that the same location? C12. Can we show me C12? Is that the same location? C12. Which one is it?
Right up there.
Show me, but what
Right
is
here.
that? What is 3132? The red one? Ah, that's not bad. So you can see where it is. It's the red thing right there. So it's actually not that far away from the previous one. Is this an RF ablation catheter?
Yes.
Do we want
We're ready
RF?
to.
Yeah, we should do RF.
Yeah, we can do RF on mapping or RF mapping.
I was thinking
To
maybe we
see-
do PF. No, do RF. Let's do it the right way.
Okay, ablation.
Okay, so so did you guys see that, by the way? So if you look here on the Egf map, on the far left, the big red spot, that is the one that's the most common. And then if you look at on the bottom, that shows you in each of the 2-second intervals how frequent it is. So we're just sort of scanning through all of them, and you can see on the
35
individual
hops.
2-second maps. It's not there, notice, 100% of the time, but it's there, what is it, 46%
35
of the
hops.
time? Yeah, it's there 46.6% of the time. That we would consider a pretty
35 hops.
high source. Anything that's above 26% or 26.5%, we consider a targetable source.
Point.
Any questions?
So, and again, so Toshi is actually ablating there right now, just trying to cover this region. We're getting good impedance falls?
No.
They're okay.
Point.
So, Vivek, maybe can we go to other two labs just to sum up for a few minutes and then come back to you?
Absolutely.
Okay. Can we move to IKEM?
Point. Point. Take a point.
This is pre and post, huh? Jan, you're showing pre and post on the right side? Good. Sure, yeah. Or we are waiting to be... Okay, let's stay like this. Let's stay like this.
You are in Ante.
Okay, you may start.
Hello. Hello, everyone. So you left us when we were doing right superior PV lesion set. So we did right superior, and we did the posterior wall ablation in 2 rows. So once we have anchors are the frame. So Jan, could you show us so now you see the map we did after. So you see that we have the left common trunk and the right-sided veins, and electrically silent unblock with the posterior wall. So we have completed posterior box lesion. So you see the map before, you see the map after. Go, Jan, can you show us the left LAO view? And now, sorry, Jan, thank you. Transparency, please. Go back to PA, sorry, Jan. Can you show us transparency? So now you see the correlation of our lesion set. Now, please mind, so now we're, Jan, can you go lower? Okay. So now you see that we aim for a 25% overlap. So each shadow you see on so we did 6 applications in the lower row posterior wall and 25%, 75% overlap with each subsequent site, you see? So we move gently, just to move and to have 75% overlap between the adjacent lesions in order to improve our outcomes, durability. We had beautiful ice cuts to show that we're in contact. That's why we have final map. Please note that there is no some enormous extension of a lesion set. You see that our lesion set is very nicely correlating with the post-ablation map. The sharp edges, no fragmented activity on the edges. Can you go LAO? And you see clearly that the appendage is, of course, preserved. We know that there's no delayed activation appendage we like. And even on our anterior, so because it's a common trunk, the roof part, go to the roof part. Yeah. You see that we had 7 application sites in the roof part, and we encompass quite a bit of a septal roof, which we like. And now, please mind that the patient had anterior fibrosis. Can you go anterior? Patient had anterior fibrosis, and this is the map we have at this point of time. So now that we finished the posterior box, we are scared that this anterior fibrosis can perpetuate and serve as a substrate for the atypical flutter. So now we're going to go for induction for a typical flutter. If we cannot induce, we're done. So let's go, Mariska, please. Burst from 300 to 250. So now we are bursting from CS catheter, trying to induce organized arrhythmias, perimitral flutter. Burst. Go to 250, your ramp. Okay, ramp from 280 to 230.
Can we see signals?
Thank you. Now ramp to 230 to 200. Ramp it. Down. She's on a Merderon. Is this 200? Stop.
Can we see signals?
Stop. So now we induce something, and it's very, you see that we see the activation is a prox to dist on a CS. So this is very, very expected outcome. It seems to be stable arrhythmia. So I'm glad that now we are having a multipolar mapping catheter. So we have to proceed, and probably we're going to find a critical isthmus up there on the anterior part of the atrial wall. And then we'll probably have to ablate more. And now this case is getting more interesting, because if we find anything interesting on anterior wall here, like here, you see the potentials, guys? Do you see HD grid potential at this point?
Yes.
Let me prove the contact. Do you see HD 1, 2, and D3 free? Very fractionated activation. Oh, I like it. Can you make a dot C34? C34, can you make a dot? C34, make a dot. And it's just there. Is it at the same spot where we had this before? So let's prove. So can we entrain from a? Can we try to entrainment from a A34? Or Mariska, can you try to entrain from a C34? Very low activity. I'm going to try and improve the catheter contact, but yeah, unlikely that we're going to capture. Now, Mariska, stop, please. Can you entrain from A34? A34. Please, entrain from A34. Let's see, because entrain, but we're going to map this just where you're still live. If we have a good...
You are pacing from coronary sinus, not from the
Yep, so now we
HD
are,
grid.
But let us show us, Mariska. Did we capture? I'm not sure. Try one more time. Go out with output with 12 or 15 amps. Go on. Be patient. Now we're leading. Go, stop. And we're in. Okay, guys, leave us here because we have to map this arrhythmia, but it's very likely that we're going to have to perform additional ablation with Farapulse in that anterior part as we suspected. So now we're going to do left atrial map, and
can we move to another lap
after
in
that?
IKEM?
Yeah, thank you. So set up the window for mapping. Okay, we're doing mapping. Good.
On the ridge.
44?
Yeah.
So
Right on the ridge.
Should we put
Wow. Look at this. Look, guys. Look at the electrograms. First, I don't know if this is due to 2-to-1 block here, but look at B34. B34 is another side, so it's a perimitral flutter, obviously, but... Ooh, look at this. Look at the activity on B34. Huh? So there are no too much points here to give you. Let me go to the mitral isthmus. Here. Nothing there, huh? She used to have this, like, fair signals here. Nothing here. Ablated. Posterior wall. Because now, after the ablation, there are no too much signals left.
No, tam nikdo není na trojce, už skončili.
Okay, I'm waiting for the acquisition. It's not stable. Now, I agree with you guys. I agree that now, but see the activation on CS. It's wobbling? Yeah, it is. So now we are dealing with unstable arrhythmias. Yeah. And the cycle length is, of course, like this because of...
I think it's not ATAC anymore. Ante, I have a question. Wouldn't you be afraid of damaging AV node if you would ablate with pulse field in this lower septal area?
Yeah, we would never ablate that. So we would gently we would do Anic not to come close to the annular region. We would ablate here and likely stay close to the roof, septal part of the roof. So we have experience in 3 patients so far, and hopefully we could avoid. But I agree with you that, and it's a operator sense. You have to have a good sense of how far are you from the node. And I do agree that we have to pay attention here. So now that we have disorganized rhythm, it's not any more organized. We are likely having something closer to the AF than because she's on an ME or whatever. So now it's our call whether we finish the procedure here and see how this is AFib. Or we do extend the lesion set from the roof part, from the septal roof, gently to our interior to encompass this part that we managed to see. It's inside. It's very fractionated, and there's no. Now we cannot map it.
The problem is that we have this 35 millimeter catheter, and this will cover all this.
No, but we're gonna position it strategically, not to we're gonna half of it gonna extend from our scar, so we're gonna gently shave it from anterior anterior rim of our ablation lesion set and go gently anterior. So it's doable. It's doable with Farapulse. Of course, it's easier to put a few dots with the RF, but maybe we can do it with Farapulse here also. Yeah.
Okay, so I think we will move to Homolka.
Yeah.
But we have to finish in a few minutes, maximum about 7 minutes, not to cut time for lunch.
Oh, you guys can hear? Okay, great. So let me tell you what we did. So show on Cardo, Stefan, exactly where the lesions are. Can they see it? Yeah, actually they can see it. It's okay. So you can see on the Cardo map, just sort of lateral underneath the appendage, we put a number of ablation lesions there. Wait, Martin, shh. Okay. Martin, shh. I can't. Okay. So, sorry, it was just loud in here. That's where we place the ablation lesions. Then we put the basket back in position, and we repeated the map. So now if we show the Egf map, please. Oh, they can see it. Okay, good. And you see there a big hot spot still, and that's 46% of the time. So the ablation, what it did, and if we look at that location, can you point that out, Stepan? It's basically, well, no, if you rotate the map to the left a little bit, so right there, right in that location is where the new hot spot was. And it may be either this sort of push that there, or maybe that was there the whole time. It's just not clear. So what we then decided to do was we put the Farapulse catheter in that location. I think we recorded it, didn't we? I did a quick cine. Can you show the cine, Stefan? The last cine? Oh, there it is. Okay. If they can see on fluoro, yeah. So we put the Farapulse catheter there, delivered 2 lesions, and now we put the basket back in position. So let's just show the live. So this is a live, let me just do a quick cine. Okay, this is the live position of the basket. So we put the recording basket back, and now we're acquiring another acquisition. Do we have it yet? Okay. So it's still there. Yeah, can we see it on Cardo now? Can we, Stefan?
I have a question how you can see now any signals, because after this pulse field it should disappear.
Yeah, the signals completely disappear. The problem is that we don't know exactly where the Farapulse catheter was, right? The PFA catheter is not linked to the system. I mean, the real problem we're dealing with is we're constantly going between systems. And it's just not a seamless situation. And this is what we have to deal with until we get their final system that we can play with. But right now, it's a bit kludgy, let's say.
Vivek?
So,
Hello, this is Hiroshi.
Yeah.
Can you hear me? So the your
Hiroshi.
hotspot showing like a rotation activity or centrifugal focal pattern?
Yeah, I think it was, we can look at it. 1 second, I'll show you. Let's take the basket back. You know what, let me do this first where I capture this like a snare or something. Okay. So are you gonna, can we show them? Is it rotational or is it a hotspot? It's more focal. It looks more focal, Hiroshi.
Focal means you're expecting like a epicardial rotation activity, endocardial breakthrough, or like a focal firing.
Maybe.
Or that's
Yes.
still we need to
that's-
figure out. Yeah.
Can we see it? Oh, there. Yeah, and look, the reality is we don't know, right? It could be either. It could be, all we know is it's a focal mechanism that's emanating from that location. So what we're doing right now, I know we're running out of time, so let me just explain quickly. We put the FARAPulse catheter back in, and now Stefan and Martin are linking the 5 electrodes on the FARAPulse so that we can try to visualize them on the Cardo system. So they're going to show it in just, we're ready to go show it? Okay, good. Okay, 20 pole A. Yeah. Okay, hold on 1 second. Okay, where is it? Not yet. Let's see here. Let's see. I don't see it yet. There's some. Oh wait, no. Is it linked properly, Stefan? We don't see it.
So if I understand now correctly, you try
here it is.
to do lesions on
Okay,
the
now try.
mitral isthmus. Or in that area.
Yeah, if we can't get this to work, we'll just take the ablation catheter and we'll ablate with that. But
well, okay. I'm
it's on
afraid
the
that
chest,
we
Stefan.
have to close this session because
I got it.
We are already
Let me just
15
make
minutes.
one last. Right. No, I got it. Let me just make one last comment, though. Let me make one last comment really quickly. Let's say we're going to make some lesions. The dot's going to disappear. Okay, I'm confident about that. I'm not confident that the AFib will terminate. Okay, it may or may not terminate. We may end up cardioverting. And I'm sure that you're thinking in the audience, well, what's so great about that? You didn't terminate the AFib. But I just want to be really clear. I mean, in the big picture, if the ultimate procedure is to isolate the veins to get rid of triggers and ablate the 1 or 2 potential sources, in my mind, that's still a much more preferred procedure than something where we wipe out half the atrium completely empirically. So that's the vision that we're trying to get to. So I just wanted to sort of make that comment. But thanks again for persevering with us. We'll let you know what happens to the next session.
Well, thank you very much for demonstration, and maybe just final touch in IKEM in that. But I see that they are coming back with FARAPulse. They probably will do this anterior septal part. So
yeah. Welcome
just
back.
Just 2 minutes, okay? 2 minutes, just to sum up.
2 minutes. So we mapped this arrhythmia where it was stable. We see that it's definitely contained in that anterior aspect. So we're going to apply two application sites over there in the anterior, gently standing from anterior. This is our plan, okay? So, and then we'll give you a feedback when we come back. So we are coming up with a FARAWAVE. Let's go.
It's not.
It terminates. Sorry?
We don't have the flow.
Did you cardiovert the patient, or it went spontaneously?
No, it terminates spontaneously.
Okay. Okay, so I think we will stop now.
Thank you, and we're gonna
transmission.
give you
Thank you very much for demonstration. There are 2 questions on the chat. One is whether the irreversible lesion, do you have any long-term follow-up for single-shot PFA devices? Yes, there is a paper. You can read the paper and it's really not bad. And we have also data from remapping, as we mentioned already several times today. The other question is about the size of Farapa, so it can go 35 millimeters, so you can cover a single big vein. We know from anatomical studies that usually it's up to 30, 32, 33 millimeters diameter, so you can cover the whole area, and you can also move this around, so you can cover definitely the whole room. So it's not problem of the size. So I answered two questions from the chat, and I would like to stop this.
Can you pace Farah 4-5 with the 600? Very nice, very nice. This is what we need, okay?
To finish this session, and we have lunch, so don't forget to come back at 2 o'clock sharp.